Hi, my name is Annette Sikorsky, and I'm currently the clinic charge nurse at the UVA Cancer Center over in Fishersville. Previous to my current role, I was an infusion nurse at the same location, and previous to that, I was an inpatient nurse on the stem cell transplant and oncology units. So I've spent most of my nursing career so far in oncology and dealing with patients and their treatments. Currently, the topic that I chose for my change project is to implement effective interprofessional communication in the ambulatory oncology clinic and infusion centers. And the problem that exists currently is that even though we operate in the same building and we are two sections split simply by one hallway, there are still gaps in communication between clinic and infusion staff. And the impact that this can have includes delays in care, miscommunications, staff frustrations with each other and situationally, and patient safety concerns is the utmost concern that we have. So the goal of my change project is to create a well-oiled machine by improving collaboration and clarifying roles and establishing reliable communication pathways to utilize within the cancer center. So for strategies for my change, our first strategy is defining roles and responsibilities clearly. We have several different tiers of staff that work in our clinic setting and our infusion setting, including registered nurses, licensed practical nurses, and certified medical assistants. And especially when it comes to RNs and LPNs, the scope of practice can be a little bit hard to differentiate. And so defining clearly what each person's role and responsibility is really helpful when it comes to communication, especially when it comes to finding the right person for the right job and understanding what you're asking somebody to do and whether or not it's in their scope of practice or if this is the most appropriate person to ask. Our second strategy for change includes implementing the Vocera paging system and Vocera badges that we wear within the clinic and the infusion centers. Vocera is a really great pathway for communication, especially because it allows for in-the-moment text paging when it comes to infusion nurses needing to ask a doctor a question, or even communicating from nurse to nurse if we don't have time to stop and have an in-person, face-to-face conversation. It also kind of sets the standard for across the service line for our method of communication between nurses and physicians. It also allows for our staff to contact one another if we are stuck in a room, if we need extra supplies that we did not anticipate, if we're in the middle of a heart stick and don't have hands to leave the patient and find help. Vocera is a great method for communication, and it also reduces staff frustration when it comes to finding somebody who is helpful in the moment. Our third strategy for change is to strengthen clinic and infusion relationships. Clinic and infusion right now have a somewhat tense relationship. We're handing patients off all day long, and I like to say that we are two arms on the same body. So we're always working to care for our patient as best as we can. But having a good working relationship and feeling like we can approach one another without fear or worry of how the other person is going to perceive our approach is a really important thing to do. So strengthening that relationship between clinic and infusion is a really major strategy when it comes to implementing this change. Structured escalation pathways. This is a huge deal. So understanding what pathway we utilize for what problem is kind of one of those things that will allow for us to implement the quickest, most efficient way for a nurse to get what they need, especially an infusion nurse who is sitting and waiting for a provider to clarify what they need or want for their patient. So using things such as the Vocera paging system, or knowing when things can be triaged appropriately within the Epic in-basket is another huge deal. Knowing how to escalate things, or whether something is an emergent situation that needs to be taken straight to the provider and is worth interrupting a clinic, is a huge deal as well when it comes to the structured escalation pathways. Oftentimes now, in current state, we find a lot of provider interruptions for things that are non-urgent or emergent, such as refills that a patient is requesting while they're in an infusion chair, a small rash that is not going to change whether or not a patient is going to get their treatment and is a non-urgent need. These things can always be taken care of using the Epic in-basket and triage system, or utilizing our RN care coordinators appropriately to help with these scenarios. And the fifth strategy for change that I have come up with to implement is the consistent use of the Epic status board. This is another huge portion, especially as our clinics and infusion centers get busier. The status board will help with room turnover, and also with knowing where a patient is in their visit and when. It also can tell us how long a patient has been in a room, whether they are still in the room and maybe need something that we were unaware of, such as labs, an injection, something like that, or whether they have moved along in their visit and now they are no longer in the room but in the infusion center in an infusion chair. Consistent use of the status board helps to expedite the process for other patients who are needing to come back and start their visit. So the status board is a huge tool to be used. As far as a timeline for implementation, I broke it down over a 6-month time period. So in month 1, we assess our current communication challenges and where things are in current state, and just start to educate the staff on the roles and scopes of practice, as well as the escalation pathways that will be laid out and put in place. And also in month 1, training staff on proper status board usage with a color-coded guide to kind of help with a smooth transition and a smooth start of using that tool. In months 2 to 3, rolling out the Vocera badges and paging system is a good place to start as well. Also beginning joint staff meetings between clinic and infusion both to reinforce interdepartmental collaboration. That's another huge piece of the puzzle. And allowing open discussion in those meetings to address staff concerns. In months 4 to 5, formalizing the structured communication and escalation pathways. So really nailing down what constitutes an urgent or emergent interruption versus something that can be triaged via the Epic in-basket. And then also conducting staff surveys on how they think the effectiveness of this is going, and collecting data on how many provider interruptions are occurring and evaluating the appropriateness of those interruptions. And then in month 6, we evaluate this change's success using survey and data results and compare them with our baseline findings. And of course, as always, adjusting our strategies as needed for continuing improvement. Areas of support and resistance. Areas of support include that from leadership, especially when it comes to management and charge nurses. I think that this change supports smoother operations and enhances patient safety. Infusion nurses are probably likely to welcome quicker assistance when it comes to scenarios that they need help with. Our triage nurses are very quick, and so having their needs that their patients are asking for addressed in a timely fashion is always a good thing. And then patients, of course, are a big area of indirect support, which is shown through patient satisfaction scores and also perceived improvement of care. Areas of resistance, some staff, especially seasoned staff who have been at the infusion center or the clinic for a long time, may have some resistance to newer technology, such as the Vocera badges. And a lot of staff who have been at the infusion center and the clinic for a long time also prefer that face-to-face interaction with a provider, and they want to just be able to walk over into clinic and have their need addressed right then and there in the moment. So that may be a big area of pushback, as well as maybe concerns about increased workload from meetings and the interdepartmental collaboration, or additional documentation. Fear of that is always a big component. All that, plus skepticism about whether these structured escalation pathways are going to really get the needs met in a timely fashion, or whether they will really reduce provider interruptions when they are within clinic. So for expected outcomes for this change, we can expect safer and more efficient patient care, stronger teamwork and job satisfaction between both clinic and infusion, higher patient satisfaction and perceived quality of care, as well as perhaps Press Ganey scores, and then better preparedness for our rising patient volumes because our clinics are getting busier and busier every day. In conclusion, communication is a pillar for the foundation of safe and efficient oncology care. A 6-month plan helps to ensure realistic and sustainable change within the cancer center. And by committing to structured communication today, we can guarantee safer and more efficient care tomorrow. Thank you.